taking, you have to ask all these questions about alcohol consumption, blood transfusion, the IV substance abuse, even tattooing is important, and sexual behavior, travel history, drug intake, family history of liver disease, obesity, and lack of proper nutrition. All these things are very important. And patients usually come with all these complaints of fatigue, loss of appetite, and vomiting of blood, easy bruising, testicular atrophy. If it's a frank cirrhosis, it will be poverty above and porosity below. And this is how the patient looks with all the features. You can see the spider angiopneumonata, blood vessel dilatation, and causes are alcoholic, post-necrotic, biliary cirrhosis, non-alcohol cirrhosis, hemochromatosis, alpha-1 antitrypsin deficiency, and the phases you can classify into compensated and decompensated. And this is the various system involvement. Cardiovascular system, there is a decrease in SVR, increase in cardiac output, so there is an hyperdynamic circulation. And hematology, it can be anemia or coagulopathy, and it can be immunodeficiency will be there, which can produce spontaneous bacterial peritonitis or sepsis. And only the patient can be hypo or hypervolemic. And renal, it can produce hepatorenal syndrome. Whereas in the respiratory system, they can ask you all about hepatopulmonary syndrome, portopulmonary hypertension, orthodeoxia. So these questions are you have to be thorough with. And acid base, the albumin changes, nutrition lack, and in the GI system, esophageal varices, nausea, and jaundice. And glucose, commonly they go for hypoglycemia because the liver is not able to store glycogen once it is damaged. And encephalopathy going on to flapping camera. And the encephalopathy is graded into 4 grades. What is the name for the grading? Any idea?
Seven.
It's called West Haven grading. Excellent. So grade 1 is almost normal. Grade 4 is extreme coma. So it's called West Haven classification. And skin, it produces pruritus and petechial hemorrhages. And this is how the normal liver changing into cirrhosis. And another risk of chronic cirrhosis is it can change into hepatocellular carcinoma. And this is the pathway of ethanol metabolism in the body. Ethanol major pathway, accessory pathway, and inducible pathway. So it is first in the cytosol of the hepatocyte is converted into acetaldehyde, and then in the mitochondria it is converted to acetate, and that acetate goes into the circulation. So this is about the hepatic blood supply, and what are all the factors controlling, like intrinsic and extrinsic, and then the portal vein, the important receptors present in the portal and hepatic artery. That also is another thing, which drugs which can affect that. And applied histology. So this picture is very important. This is the classic hepatic lobule, the hexagonal one, with the portal triad on all the 6 areas and the central vein. So this is mainly for venous drainage, for to go to the hepatic vein. And this is the portal lobule, which connects the 3 adjacent central veins. And this is mainly for biliary drainage. So from the hepatocytes, when the bile is secreted, it goes towards the biliary canaliculi to be collected and then taken to the hepatic biliary ducts, then to the common biliary duct, and right and left hepatic duct, and then biliary duct. This picture of the somewhat rectangular, trapezoid shape, this is for the portal acinus, where the blood supply closer to the portal triad, it is zone 1, little away zone 2, and closer to the central vein is zone 3, where hypoxemia affects. So if you remember these 3 pictures, this is for venous drainage, this is for biliary drainage, this is for the effect of hypoxemia on the various zones, which will affect the enzyme function. And so this is another important thing is the blood reservoir function of the liver. Apart from all the metabolic and synthetic functions and the immunofunction, another important function is it is the main blood reservoir. So in case of trauma, it can supply up to 1 to 1.5 liters to the systemic circulation. And of course, these are all various metabolic functions. Then the cardiovascular effects, then the coagulation, endotoxemia, and the alcohol metabolism. These are all the enzymes that are used, and this is the method by which it is, and how the alcohol affects the liver and causes the inflammatory response and leads to first inflammation, hepatocyte injury, fibrosis, and impairs the regeneration also. So in cases which become very severe cirrhosis, the ability of the hepatocytes to regenerate is also affected. So that is the reason why they become severely cirrhotic. And systems involved, of course, again we get the risk classification. This is cirrhosis related risk factors. These are all the things which are taken into account. Like we have a scoring system plus the parameters that are taken are the albumin level, platelet count, ascitic encephalopathy, varices, portal pressure, and the surgery related factors, demographic factors. All these things have to be taken into account. The investigations we commonly do for any surgery plus PTINR is very important for indicator of the prognosis and severity. Platelet count and assay. Selective mainly you must concentrate on albumin and bilirubin, and RFT for finding out evidence of HRS, electrolytes, and then use the abdomen to find out the enlargement of the spleen. And then there is a new scan called fibroscan to assess the stage of cirrhosis by the texture of the liver. And you have to go for EKG and X-ray to rule out alcohol-induced cardiomyopathy and pleural effusion. That is the reason why you want an X-ray test. And risk assessment tools are the commonly used is the CTP scoring system, which all of you are aware of. And then MELD came mainly for giving priority to liver transplantation. And then the other thing is adopt LC score, adequate operative treatment for score, where you take into these four things. Sorry, patient age, child Q score, Charlson comorbidity, and estimated duration of anesthesia. This is the fourth thing that you take into, and based on that you can get a point. So this is more like an app which is available in many of the net. So you can use all these parameters and get the predicted hospital mortality following surgical procedures in percentage itself. Then the albumin bilirubin score combining serum albumin is mainly for assessing the severity in hepatocellular carcinoma. And there are 3 grades in that. And portal hypertension, how it develops, that is another question that can be asked. It can be an neutrophil overflow or vasodilation theory. All these points you can get from your books, there is no problem. And the portal pressure gradient is very important. The normal range is 1 to 5 millimeters of mercury. And when the value of the gradient becomes 5 to 9, this represents a subclinical portal hypertension. But once the gradient goes to more than 10, then all the complications of portal hypertension will happen. And this is the difference between the hepatic venous pressure and the IVC pressure. That is the difference. How do you calculate the portal pressure gradient is the difference between the hepatic venous pressure and the IVC pressure is the method of calculating. And the portal hypertension types, it can be prehepatic, intrahepatic, and posthepatic. So all these thrombosis in the portal or splenic vein, then sinusoidal idiopathic portal hypertension, all these causes are there. and the hepatic venous pressure gradient less than 5 is normal, 5 to 10 mild, more than 6, 10, like that it goes on increasing. And gastroesophageal varices, the common sites of portal cavern anastomosis, that is another question that will be asked. And commonly we get it at the lower end of esophagus, lower part of rectum, para-umbilical region where it becomes the caput medusae, retroperitoneal, and patent ductus venosus, which is intrahepatic portosystemic shunt. And in severe cases, we have to, conservative treatment is what is called TIPS, transjugular portosystemic shunting. And the etiology is liver root cause. So how does it affect and produce HRS is the one, portal hypertension causing splanchnic vasodilatation, decreased effective circulatory volume, so renal vasoconstriction and hepatorenal syndrome. This is the pathophysiology of HRS, and HRS is graded into type 1 and type 2. And what is the treatment? That also is another important thing that they can ask you about the vasoconstrictors, albumin, mass, removal of toxins. All these things are all part of treatment of this HRS. And, in the lung, there are two things which may be asked. One is a hepatopulmonary syndrome, another is the portopulmonary hypertension. So if you see this picture, in a normal lung, there is an alveolus and there is a capillary subserving each and every alveolus. In the portopulmonary hypertension, what happens? There is a vasoconstriction and there is a vascular obstruction leading to increase in the pulmonary pressures. Whereas in the hepatopulmonary syndrome, there is a dilated capillary and there is a angiogenesis also causing. So this pulmonary, this causes of excessive blood flow and shunting. This is increases the pulmonary pressures mainly. Why hyperdynamic circulation? Accumulation of prostaglandins and the interleukins, which are vasodilators, cause an increase in cardiac output and decrease in SVR, and reduce blood viscosity due to hypoalbuminemia. And anemia also play a role in the hyperdynamic circulation. And there is a cardiomyopathy, diastolic dysfunction also can happen, mainly coagulopathy in the form of increase in INR. So primary hemostasis, coagulation, fibrinolysis, all the three things are involved in the coagulopathy in liver disease. So how to optimize? First, to take care of the nutrition, hypoglycemia, hyponatremia by giving aldosterone antagonist, correct potassium levels, watch for early signs of encephalopathy, and then oxygen saturation in patients with hepatopulmonary syndrome or portopulmonary hypertension, and paracentesis to improve oxygenation if the patient has very severe distension restricting the diaphragmatic mobility. And if there are more than 4 liters are tapped, infuse albumin. And earlier they used to have what is called leave-in shunt to direct the ascitic fluid back into the circulation. And the correction of coagulopathy by platelet fibrinogen or TEG, that is thromboelastograph, injected vitamin K 10 milligram IV for 3 days, and you must keep all the blood components ready depending upon the TEG value, and prevent infection and sepsis, and transjugular intrahepatic in selected cases of refractory ascites and decreased renal function. So tips is only for these two indications, refractory ascites or gradually declining renal function. And MARS is another one. This is called liver dialysis, where you can remove the toxins or drug overdose. And goals of anesthetic management: preserve hepatic blood flow. That is the most important goal. And factors decreasing hepatic blood flow will be mechanical ventilation, keep them to the lowest possible, hypercarbia and hypoxia, hypotension, stress of surgery, and then monitor and maintain renal function, prevent CNS depression and encephalopathy, prevent coagulation failure, maintain normoglycemia, preserve electrolyte balance. Coming to anesthetic management, for most of the cases of liver disease, altered pharmacokinetics is there because of increased volume of distribution, decreased protein binding, and decreased clearance. So induction agent of choice is propofol because it has extra hepatic elimination and it preserves the hepatic arterial buffer response. These are the two reasons why propofol is considered as the ideal agent. And relaxant of choice will be cisatracurium. Analgesic, if remifentanil is available, you can use that. Otherwise, titrated doses of fentanyl will be good. Inhalation agent, isoflurane and sevoflurane, again with the idea that they preserve the hepatic arterial buffer response. Reversal with titrated doses of neostigmine. Monitor between mild to moderative in severe cases. So in CPT B or C group, you have to go for invasive cases, but be aware of the coagulation profile. And the regional is safe if coagulation is okay and SVR is not too low and level should be below T10. Post-op care, watch for features of acute liver failure, altered sensorium, increasing jaundice, monitor renal function, monitor coagulation, avoid infection. Paracetamol should be used very cautiously because paracetamol is mainly metabolized in the liver and if the dose is not properly titrated, it can produce paracetamol overdose, which itself can precipitate liver failure. And so, what you have to know is histology of liver, anatomy of lobes of liver with ligaments, control of hepatic blood flow, bilirubin and bile physiology, test of liver function, role of liver in the drug metabolism. The types of cases you can get are cirrhosis with portal hypertension, obstructive jaundice cases with CA head of pancreas or gallbladder stone, the common bile duct stone, and segmental hepatectomy for secondary deposits, end-stage liver disease for liver transplantation. So these are all the clinical cases with which, of course, we discussed about hematemesis also in this case. And anesthesia sometimes for ERCP also can be asked. And of course, we will not go into the other details. And